I want to thank everyone for joining us today for Dementia Friendly Tempe Presents. My name's Candace Hewitt and I work for the City of Tempe as a Senior Social Services Coordinator. I'm responsible for Dementia Friendly Tempe programs, such as the Memory Cafe and these monthly presentations, which are scheduled on the second Wednesday of each month. Each presentation has a different topic related to caring for a loved one living with dementia. For more information on future presentations, please visit our website at www.tempe.gov/DFT. We will provide this information again at the end of the presentation. Today's presentation is Ask the Doctor Any Questions About Dementia. Our presenter is Dr. Ed Perrin. Moderating the discussion will be Jan Doherty, who is a nursing expert and leader in the dementia care field. And she's also a member of our Dementia Friendly Tempe Action Team.
Thank you, Candace, and I couldn't be more delighted to be participating in this session. You know, every year it seems like we have so many questions that come up in Memory Cafe and support groups that really need the expertise of a physician who is knowledgeable in the care of older adults. And today we are so fortunate to have Dr. Edward Perrin join us. I've had the privilege of knowing Dr. Perrin now for a number of years, and I can tell you that he is just an amazing individual, first and foremost, who is boarded in family medicine, palliative medicine, and is also a geriatrician. So I will be looking for questions from you all. Again, this is meant to be an open forum. Dr. Perrin does not have a formal presentation prepared, as this is really meant to be a discussion between you as participants and Dr. Perrin, and understand that this will not represent his giving you orders over that of your own medical provider, rather than he is responding as a physician to questions and concerns that frequently come up from patients and families. You'll see from this housekeeping that there are a couple ways for you to join today. You can either raise your hand, and again, on my screen, right below in the center, if you hover your mouse in that center area, you're going to see a couple different options. One, if you want to raise your hand and ask a question, there is a little thought bubble with two lines that come up in it. And this is one way that you could just type your question into the chat pane. We'll see those to be able to ask Dr. Perrin. The other thing that you can do is raise your hand and request actually to ask your question live, if you will. So in that case, you will need to unmute this microphone icon that you see, and it's optional if you want to take your video camera off of with the X, we would see your face. That's completely up to you. But as you formulate your questions, and hopefully you've all come with at least one or two, I would like to first of all welcome Dr. Perrin, and I would like him to begin by telling us what is a geriatrician and who benefits from seeing geriatricians. So Dr. Perrin, if you would unmute and maybe put yourself on video, that would be terrific.
Okay, well, thanks, Jan. Thanks, Candace. And I want to thank you all for joining us today. It's a real pleasure to join Jan again. It's been for 2 years, and it's fun to collaborate. So thanks. I do have a question, Jan, for those guests who are on phone only. How do they on?
So I'm not sure. Candace, maybe you can tell us, or Allie, how will the people on phones be able to ask their questions?
They should be able to, that's a very good question, Allie. Are you aware? Are they able to use their keypad to put a question in to chat?
I think we may need to just make sure that they are unmuted. I'm not sure they're able to unmute themselves. So the folks that are calling in, we can unmute them and leave them unmuted. We'll just need to be very mindful that they don't have background noise. I will mute anybody that if there's a bunch of background noise that gets distracting. And then Dr. Perrin, you were cutting in and out a little bit on your sound, so I think it'll be probably important for you to be kind of near your screen just so we don't have any cutting in and out.
Okay. Is that better?
Yes, thank you.
Okay. Yeah, I'll just lean forward. So thanks again. And I suppose if you do have a question and there's no way to raise your hand or chat, then just shout it out and we'll see if we can take it. Let me back up for a moment, Jan, before I answer your first question, sort of let everyone know who I am and why you asked me that question. So I'm a family doc first. And so the way medical specialties work is you need a primary certification or a primary specialty. And there are a lot of those that can be internal medicine or OB-GYN or pediatrics, or for me, family medicine. That's my primary specialty. And then once you've completed training of at least 3 years in your primary specialty, one can go on and get additional training and certification in subspecialties. And geriatric medicine is one of those subspecialties. You can only become a geriatrician if you're either primarily a family medicine doc or an internal medicine doc. Those are the only routes to become a geriatrician. There are, like Jan or like Candace mentioned, I'm also, or I think Jan mentioned, I'm also board certified in hospice and palliative medicine. And there are about 9 different specialties that can get you into that secondary specialization. So it's not as sort of restrictive in the way that geriatrics is. So with all that being said, I'm a family doc first and a geriatrician second. And the way I like to think of myself is that geriatric medicine is very much what family medicine is, but kind of amplified or on steroids or sort of squared, if you will. So everything that I deal with in my family medicine office, when I put on my geriatrician hat, it sort of magnifies all the issues that I think about as a family doc. And that's what intrigues me, what attracts me to geriatric medicine, is that all the strengths and weaknesses of a patient when they come see me, all of those tend to be magnified as they get older. And so geriatric medicine, very simply, is taking care of older patients. And that's, I think, what Jan was getting at, is what does that actually mean in practice? And when I teach the medical students, I work a very small amount of time at the medical school here in Phoenix, the University of Arizona, and I work with med students and help them in part of their geriatric curriculum. And I ask them, what does it mean to be old? And they always have some ideas, and I think all of you will have some ideas. And I think the bottom line is there's no one answer for what makes someone eligible for geriatric care. There's certainly no cutoff, but there are some arbitrary ones. And one of the ones I like to say is that for me as a doctor, any geriatric patient, they are going to be 10 years older than me. That makes them geriatric. And so as you can see, they only get older as I get older. And it also keeps me out of the geriatric stage myself. That's kind of a joke among us geriatricians. But there are certainly geriatric syndromes, and that's really what I think is important. There's sort of 2 things that make me think about a patient differently when I want to approach them as a geriatrician. One is going to be certainly their age, but also probably more importantly, what are the syndromes that they might be affecting them? And obviously, sort of the prototypical geriatric syndrome, or the quintessential geriatric syndrome, is dementia. It can happen in younger people. So that's why an arbitrary age cutoff doesn't really work when we talk about geriatric syndromes. It's really about what does this disease process bring to the patient's life, and how can we approach them in a slightly different fashion compared to a typical patient. And those geriatric syndromes, of which dementia is but one of them, just happen more frequently in older patients. The other thing that I think is important to recognize about geriatric care, and this is sort of a cornerstone in the discipline of geriatrics, is that geriatric patients, older patients, tend to be more complex. That's what, again, attracts us to this field. But it also means that I'm just the doctor. And what geriatric medicine requires, by definition, is a whole team of professionals, and sometimes non-professionals, to take care of patients that are older or that have geriatric syndrome conditions. And so that's how I know Jan through the geriatric community. Jan is not a doctor, but she's an essential element of the geriatric care team, being a nurse. And I think that's really important as just the doctor. I have other allied fields and professionals in my orbit that I can call on to help take care of my patients. And so, all in a long-winded way to say, Jan, when who do I want to see in my practice as a geriatrician, it really comes down to what are the conditions we're thinking about and how do we want to approach somebody. Not everybody who's 10 years older than me, not everybody who's 65 plus, not everybody who's even 85 plus needs to see a geriatrician. There are 58-year-olds who probably would benefit from seeing a geriatrician, and there are 90-year-olds who have no need to see me as a geriatrician. And so it's really, as all medicine should be, it's sometimes hard to do in today's modern world, but as all medicine should be, and certainly geriatric medicine should be, is really a case-by-case individual approach to this patient. What is it that's unique about this patient who happens to have these conditions that makes you maybe more beneficial to see someone who's boarded in geriatric medicine? Jan, does that sort of answer the question in a very sort of roundabout?
So I think what we're hearing is that these are folks who are fairly complex, who have more than one thing going on, or maybe have one thing going on that is really dominating life and putting them in a downhill trajectory that you and other team members might find better ways to help them live their lives in a more successful manner, or help their families in doing such. And certainly dementia becomes a very significant role for most geriatricians, since we know that age is certainly the greatest risk factor for developing Alzheimer's disease or related dementia, but certainly younger people can develop it as well. So what I'd like to do is, I don't see any questions in the chat pane. I'd like to ask people to unmute and ask Dr. Perrin anything you want about dementia, or maybe an age-related concern. And if you don't have questions, I've got a bunch of them.
You can see I'm sitting in my office. I just recently switched practices to a primary care practice. I've been working for the last 10 years primarily in the Medicare space, so vast majority of my patients were only Medicare patients. I was really seeing a much more geriatric population. I have switched to a new practice where I'm seeing for everybody, back to my root family doc. But I have slightly different, starting to see more older.
So Dr. Perrin, you're kind of breaking up again. If maybe you moved a little closer to the mic, thanks.
Okay, and we have two hands up.
Yeah, Debbie, why don't, let me begin with Debbie, just because I see your hand up, and then whoever's hand up is second, I'm going to see if I can figure that out. But Debbie, let's begin with you. Ask Dr. Perrin your question, please.
Okay, my mom is 95. Bless her. And just the last couple years, the dementia has set in. And our biggest concern is this obsession she has with what day it is. And does she have something to do? So we gave her a paper calendar. We write all her appointments on there. And she'll look and she's focused. Today is Wednesday. And 5 minutes later, it's like, what day is it? And it's like, okay, Mom, we got her a big calendar to look at, an electronic one. It shoots the day, Wednesday morning, the date, everything on it. And I just don't know what to do for her.
A great question. Not an uncommon experience, I'm afraid. If we were in a room, I probably would look around and see a number of you nodding your heads in agreement, Debbie. So thank you for asking. You know, I think one of the questions that we need to focus on in geriatrics and certainly in dementia is, who are we treating? So I think, Debbie, you've highlighted this is a concern that doesn't bother your mom at all. She's happy asking you the question over and over and over, being confused or forgetful about what day it is. And so when I come in as your doctor or as your mom's doctor, it's going to be really important for me to understand what's the real goal here. Is the goal for her to know what day it is, or is the goal for you to be not bothered by her asking? Because those are two very different approaches to the same problem, depending on what perspective you're at. And so we first have to answer that question. What's our goal here? Because if the goal is for her to know what day it is, I think you're already gone down that line. You're using technology, you're using reminders, and perhaps there are medications around this, around obsession or around memory or around orientation that might help. Am I breaking up? Am I?
You're okay.
You're good.
Okay. And so there may be other sort of interventions we can think about if we want to improve her memory or improve her orientation. Now, dementia, almost by definition, gets worse. And so that goal may be more and more out of reach as her disease progresses. If the goal is for you not to be as bothered by her questions, then it really becomes, how do we help you manage her repeated questioning? Because that may not end for many, many months or years until she enters a different stage or phase in the dementia.
Okay, and that's probably part of the problem, because there's 5 daughters and we all stop by, we all try to help her, and the frustration is it doesn't seem to help no matter what we do. So in my particular case, it's more, I'm brokenhearted that I can't help her. And I just don't know what to do. If it's just a matter of letting her ask the question and answering it, okay. I just don't know what to do for her.
Well, you may already be doing enough. And I think being brokenhearted is a very common experience. And I'm sure you've talked in this session before about anticipatory grief and ambiguous loss. And so being brokenhearted makes sense. And maybe you just need to recalibrate your and your sister's expectations about what your mom can or can't do. And once that recalibration occurs, people sort of find a new happiness rather than keep on trying to fix something.
Okay, that makes a lot of sense. Now I just got to get 5 women to agree.
Siblings, yeah.
Thank you very much.
You're welcome.
Yeah, great question. Certainly a very common one that's so frustrating, especially for caregivers. So now I'm going to turn to whoever is E, the letter E. Would you go ahead and unmute yourself and ask your question to Dr. Perrin? So E, registered as E. I can't see anything beyond that. There you go. It looks, we just need you to unmute, or Candace, if you're able to unmute E, maybe that individual can ask their question.
Unfortunately, I can't unmute them. They'll need to do that.
Okay.
So whoever has their hand up, there's only one person that we see. If you have that question, you can just unmute yourself and ask. Or if you want to type it into the chat, we can ask the doctor the question that way too.
So maybe, to kind of follow up on the question about, repetition, there can be repetition on question and a number of questions. When, Dr. Perrin, does a doctor consider when medications might be needed for those kind of behaviors that really become bothersome? whether they be bothersome to the patient or they be bothersome to the caregiver. How do you begin to assess that, and what do you need caregivers to tell you to help you understand if a medication might be needed or not? And we don't need to be talking specific medications, but just in general, kind of guiding caregivers on how do they talk to their doctors, especially if they only have 5 minutes.
Wow. Yeah. Well, that's where we all are. So good question, good follow-up question. You know, it really comes down to teasing it out. What are the goals? What are the experiences? What are the questioning or the behavior? You can broaden this. Doesn't even have to be verbal repetition. It can be behaviors that are troubling or annoying or frustrating or depressing. And then we have to talk about what's contributing to the behaviors, what's contributing to how do those behaviors or questions affect the patient with dementia? Am I audible? I just want to check in.
Yes, you are.
Okay.
Yes.
Check in. How much is it making the patient uncomfortable? How much of it might be for an unmet need that the patient is trying to express through some other question or behavior? And finally, what is its impact on those that are around the patient, particular caregivers and other family members? And then it becomes a question of what's the best way to treat this problem. And like I replied to Debbie, are we treating the patient because it's really uncomfortable for the patient? And if it is uncomfortable, what's the root cause of that discomfort? So people that, for instance, are pacing and they want to sort of get out and walk around, are they uncomfortable physically and maybe they just need to empty their bladder or move their bowels? And that's the source of this pacing behavior. If someone says, I need to go, when are we leaving? And they keep on asking that, it becomes difficult for caregivers to hear that. Maybe it's, where do you want to go? And she may reply, I want to go home and see my mother. Of course, the mother's been deceased for 40 years. So it's understanding, what does that need? Maybe she just needs a hug every time she says that. Mom says to give you a hug. And that answers that behavior for 5 minutes, for 5 hours, for 5 days, you don't really know. But again, the intervention, the treatment, we try in all of medicine to make sure that these treatments, number one, don't do any harm, don't cause more problems than the problem we're trying to treat. And number two, are effective at reducing or treating that problem. And so, Jen, again, a long answer to say, it really depends. Let's tease it out. If you only have 5 minutes or 7 minutes with your doctor, and this is really critical, bring it up, make it very clear what the issue is. Is it patient focused, oriented on the person with dementia? Or is it really oriented at those caregivers that are going around that? And then again, like with the answer to Debbie's question, you recalibrate the expectations among the caregivers and then go with your treatment. And then to answer sort of the bottom part of this question, Jan, when do we actually pull out our prescription pad or nowadays on our computer and pull up a new medicine? That really becomes almost the last resort. That's the treatment of last resort. A, they don't usually work very well. B, they often have side effects that become troublesome or problematic down the line. And C, there becomes a question of, do you want to take something every day or even as needed that has limited efficacy, limited effect, and possible side effects that then you end up chasing more rabbits trying to figure out how to treat the side effects of the new medicine that you've just started. So I'm very reluctant to start a medicine for some of these questions or behaviors or frustrations that develop because medicines often don't work. Now that's a separate question from when do we start a medicine for dementia, so there's something around that. So
yeah, I think, certainly we know that the true tale of a good geriatrician is they often are taking medicine away, not adding medicine. And I think, the message for caregivers to hear is that, one, it just depends, and two, what's the trade-off that sometimes, the benefit we get might not exceed the risk that we're bringing on with it. So a lot of careful consideration and discussion that has to happen in that time, which is a reason caregivers really need to get their conversation together before they come in right nowadays to a physician, just because our health system is pressed. I have a question from Steve that I think is really great. So Steve is caring for his wife. She's in her 9th year of living with Alzheimer's disease. And he says, they say the average lifespan is about 10 years. What are some signs of transitioning that we should be looking for? And I assume maybe, Steve, you're asking about transitioning. When do we know maybe that the end of her life is really within a matter of months? Not that any doctor has a crystal ball necessarily either.
Right, Jan. Thanks, Steve. Good question. And I'm sorry that you've had to suffer with your wife for so long. Average lifespan is 10 years, but that's, again, an average. It does not apply to any one person. So if your wife was diagnosed 9 years ago in a very early stage, she still may have several years ahead of her. If she was diagnosed in a late, early, or moderate stage, then she merely may be closer to the end of her life. And the things that we talk about in terms of what is some of the final things that we see as patients near death with dementia is pretty straightforward, actually. And I think the crystal ball is a little less murky when it comes to these questions. So I appreciate the opportunity to answer. What happens, most people with dementia that die from dementia don't die from a heart attack or don't die from getting sort of wandering out into the desert and dehydrating in the summer, which can happen. When they just simply go to sleep one day and don't wake up, it's typically, the majority of the time, it's because they've lost the ability to swallow. They've forgotten, if you will, how to swallow both food, drink, but also even their own oral saliva. We're always swallowing unconsciously. And as the brain deteriorates with dementia and Alzheimer's in particular, those connections between the brain and the swallowing mechanism start to fail. And so what you can frequently see is when your wife eats, sometimes she'll just keep the food in her mouth and literally forget to swallow. Or if she does swallow, sometimes it's dysregulated and she might cough a few times as she swallows, or even a minute or two after eating, you may notice that she's coughing. So that's a very simple way to know that, wow, it's likely she's going to be inhaling some food or even just some oral content, some saliva without food. And when those things get inhaled, either in one giant amount or over time, the lungs can get damaged. And ultimately, the lungs fail or get infected. And that's what ultimately takes most people with dementia is there's some what we call aspiration or inhalation of oral contents that the body can't get out. She can't cough it out, and so it overwhelms the system ultimately. Sometimes along the same vein, she may not be drinking very much, and we do live in the desert, and so dehydration and kidney failure is another way where they just sort of, in both circumstances, it's not a painful way. It's really not uncomfortable really at all, especially with a few medicines as needed to transition just going to sleep one day and not waking up as the kidneys fail or as the lungs fail in those circumstances. If that coughing isn't happening, there may be other things that can happen that can lead you to think that she's closer to passing than before. And that's just sort of how much is she sleeping during the day? If it's 22 or 23 hours a day, we see this both with humans and really with all animals, that as they get older and get closer, they just spend more time asleep and less time awake and interacting. If she's obviously, if she's still walking around and talking, I don't think she's anywhere close to dying. So that's another way. Those are the two big signs we see is alertness and being sort of participating in the world, aware and awake, and the other is the swallowing mechanism, because that will lead directly to complications of dementia that lead to death typically. Anne, I don't know if you want to add anything to that.
No, I think you know, there's so much variability in people and their overall general health. And the other observation that I've often had in this, you know, in the work I've done in hospice and end of life dementia care, is that sometimes there's such a, you know, this is a disease of the brain, not a disease of the spirit. And sometimes the spirit is just so strong and the work is not yet done. And you know, it's difficult because it's wearing as well. You know, it just the uncertainty of knowing when is it going to end. Not that we're wishing someone their life to be over, but we know it's also very challenging. And as caregivers, we're always looking ahead, you know, in many ways, trying to plan for when is the other shoe going to drop, and it's hard to know. So I think those are really good signs to know when there is a change. Looks like Debbie, you have your hand up again, and we welcome your question, please.
Okay, I've got two I thought about. There's been a couple times over the last few months where Mom has woken up saying she had a terrible nightmare and she comes out of her room crying. And then once in a while, she'll just pop up with a memory of her mother. And yet, you know, 5 minutes ago, she didn't remember what the date was. So just wondering if that's all pretty normal.
Oh, great anecdotes, great descriptions. Both normal, yes, I would say. We all have nightmares as we age, or as we're young, as we get older, and as we age. So a nightmare is going to happen probably with as much frequency with a demented brain as with a normal brain, because we don't understand sleep. We don't understand dreams. We just don't understand them at all. So if she really did have a nightmare, then I think it's the same sort of thing we do with anybody, with a 4-year-old a nightmare, with a 24-year-old a nightmare, with a 94-year-old a nightmare. Comfort and reassurance, and you know, make sure that she knows that we believe her. I think that's really important, not to dismiss her experience. The other question around her memories of her mother, it's a curious disease, this dementia. Short-term memory, as we all know, evaporates with these dementias typically. But the long-term memory, memories that were created and stored when she was 4, 5, 6, 7 years old, those are the last to be lost. It's kind of a reverse time machine, so that when you create a memory 5 minutes ago, it's the first one to leave, which is why she asks questions every 5 minutes. Whereas you create a memory a week ago, not likely to be there, but it's possible. You create a memory 50 years ago, it's probably still going to be retrievable in that brain because of the actual areas of the brain that are being destroyed by the dementia. And so when she talks about her mom, absolutely real. She may be living, her reality is that maybe she is a teenager and she just talked to her mom. She remembers this conversation with her mom from 80 years ago, and she wants to tell you about it. She doesn't know who you are. She might have some concept that you're a daughter or you're a relative or you're a friend or an acquaintance, and she wants to tell you about her mom. And acknowledge that and respect it and go with it. Join her journey was a common phrase we use around taking care of demented patients. So just join her journey. Tell me what else did mom say, and that's fine. It validates their reality because it is a reality. As fractured as it might be, it's still a reality. Very real and very common, and not.
Yeah, and I would add just a couple things. First of all, relative to the nightmares, one of the side effects of Aricept, if you will, is bad dreams. And so often the timing of Aricept, interestingly, most pharmacists will dispense it, say give it at night, when in fact, if she's on Aricept, it's best to give it during the day. And she's less likely to have bad dreams. So it's something to consider, Debbie, and I love, Dr. Perrin, your description of kind of, you know, memory in reverse, this reverse time machine. And yeah, it's so interesting how the role of mother, not to dismiss the role of father, but it's very, very common for almost all people to be looking for mother towards the end of their lives. So it really speaks, doesn't it, to that mother-child bond. It's an interesting phenomena, you know, in terms of the imprinting it has on our emotional memory. And so I think, yeah, those comfort strategies are so helpful. So I just heard from E. So there was some computer issues, and this is a really good one, Dr. Perrin. So his or her question is about this new medication that was just denied by the FDA last week. That's the Biogen study that was done. And you know, is there any hope that this medication or something else will be approved? Because we're like, what, 20 years with nothing new in the pipeline that has been FDA approved. So thoughts you might have on that?
Well, you know, I'm not a scientist, so I don't have access to their data. So I can't speak. The medicine was aducanumab, which is the Biogen. It was an IV medicine that was helping earlier Alzheimer patients. I'm not exactly sure why the FDA advisory panel voted against recommending approval, because I don't have all their data. I remember it was the initial data weren't very good, but they decided to submit to the FDA anyway. And now it sounds like this additional submission still wasn't enough to convince the scientists that it was going to be effective. I think the next couple of years, we're going to be seeing a lot of these types of medicines being submitted for approval, because they're the ones that are directly affecting the actual disease process of Alzheimer's. So I think it was a little distressing to hear about the vote against its approval, but I would just try to give you a little glimmer of hope that there are other medications that are similar or work in a similar fashion that may be coming up for approval in the next couple years. I agree with Jan that it's unfortunate that we have so little medicines now to treat these dementias, but because there's been such interest over the last 10 years, some of the more recent investigational studies are starting to come to fruition. So I just want to say, be a little patient, and we can cross our fingers that something will come out of that pipeline that will be more effective or more convincing of its effectiveness in the next couple of years. I think one of the challenges when I get questions about medicines to treat Alzheimer's is so many of my patients and their caregivers want something to treat the disease now, and it's not there yet. And more importantly, even when these new medicines do get approved, it's likely that they're only going to be really effective at very early stages of Alzheimer's. And so when you're really in the suffering stages of taking care of someone with Alzheimer's, there won't be much to treat. And that's just sort of understanding the pathology, the biochemistry, and the physiology of this disease. It's unlikely that when the brain is as damaged as it is when you're in the moderate stages of the really difficult caregiving times, it's very unlikely that the brain's going to be built back up and to really reverse what's already happened. So I think sort of to put a dose of realism into the hope is that these medicines are going to be much more effective at very early stages, and possibly even before we really know someone has Alzheimer's. And we're going to have to use these medicines in people with brain imaging studies like PET scans or spinal tap results or other blood tests that show someone has sort of pre-Alzheimer's. So there are a couple of other diseases that are similar to this, and I don't want to confuse the picture, but we do a lot of treatment of heart disease before someone has heart disease, and we do some treatment around cancer, and that there's some sort of similarities in both of those when it comes to dementias, when it comes to these specific types of medications.
Can anybody hear me?
Now we can.
So I think,
Hello?
yeah, it can be discouraging as we've looked at trials. But one of the things that E has just said too is that, you know, he's in the early stage, which is very disappointing. The good news in that, if you will, is there are a number of clinical trials that are largely aimed at people with Alzheimer's disease in early stages. So again, you know, with the trials, just understand you might be in a placebo group, meaning that you get the fake or dummy treatment versus real treatment. But many people in trials, in my experience, really do better because they're empowered, right? They're getting great medical care because they're routinely being seen and they feel like they're doing something, they're contributing. So that would be an option to reach out to an organization like the Banner Alzheimer's Institute or Barrow Neurological Institute. Both organizations have memory centers that are doing research. But in addition now, an interesting question that E brought up that I think we're getting more information about is the association between hearing loss and dementia. And so she asks about what's the connection between hearing and hearing aids and dementia? Can you comment on that?
Yes, great question. You're really up on your research, so congratulations. Hearing loss in particular in mid-adulthood, so sort of that 35 to 55 age span, when people experience hearing loss in those years, it is one of the strongest risk factors for future development of dementia. We don't know why, so let me just say that. But it is somewhere between 2 and 4 times the risk compared to just the traditional risk factors we've heard about, like high blood pressure and diabetes. So hearing loss in mid-adulthood is a significant risk factor and has recently been identified by international researchers. The question then is, if it's a risk factor for future development of dementia, does treatment of that hearing loss with the hearing aid prevent or reduce that future risk of dementia? And the short answer is, from what I've seen in the research, we think so. Yes, there's some indication that if you treat mid-adulthood hearing loss with hearing amplification, you can reduce that risk. Studies still have to be designed and implemented to really prove that, but we think so. Your comment about he's 74, got hearing aids a year ago, probably not relevant to his current diagnosis of dementia, unfortunately. The current diagnosis of dementia may or may not have been related to any hearing loss 20 or 30 years ago, and may be related to any number of other considerations.
Yeah, and let me just add, you know, that unfortunately hearing aids amplify everything. And so for the person living with dementia, overwhelm is so much easier when it's bringing in all this external noise. So, you know, with the holidays right around the corner, even though we're supposed to be limiting the number of guests that we invite or we join in celebrations, it's kind of a reminder to me how important it is that we control the amount of stimuli that we give to a brain that is living with dementia, and the hearing just adds to that. So, you know, there are other ways that we try to compensate. But we have a question now, and I'm going to ask whoever is calling in from the 515 area code, if you could unmute your telephone and ask the question for Dr. Perrin.
I think I'm unmuted. Can you hear me?
Yes, we can hear you.
Okay, thanks. I've been trying to get in there. My questions kind of go back a little bit to what you were talking about at the beginning between a gerontologist, or as far as having that be my mother's primary physician. She goes to the Alzheimer's Institute for her regular checkups, but then they don't provide like just family medicine type of information or help. So then I have to take her to a family physician. And a lot of times I find that her regular physician doesn't really know very much about the medicine she's taking or symptoms she may be having, or that she shouldn't take this. And so I would think that would be an advantage to going to a gerontologist, because you're more informed on maybe the Alzheimer's side of patient care. Is that correct?
Yes, I think you summarized it beautifully, which is a lot of primary care docs, internists and family docs like me, are either unfamiliar or uncomfortable or both with dementia, and so tend to say, follow up with your Alzheimer's Institute, follow up with your Alzheimer's specialist, and try to wash their hands of it. And that's, I think, a disservice, because your primary care really should be trying to coordinate everything. And therefore, it may be worth shopping around and finding either a primary care who is a geriatrician also, or at least a primary care who's a little more comfortable and familiar with some of the geriatric syndromes. Because I'll tell you, there are not a lot of us practicing geriatricians in Arizona, and certainly across the country, unless you're in a real academic center that specializes in geriatrics. And so I agree with you. I think you have really identified a concern you have with your primary or your mom's primary, and you may want to look around and or talk to the Alzheimer's Institute folks and say, you know, what do you recommend? How do I get my primary to be better at answering some of my questions? I think you're taking great steps, and I applaud you for that. Absolutely.
So the other comment I would have from my nursing discipline is to consider a geriatric nurse practitioner. So sometimes, you know, again, physicians are often using nurse practitioners in their practice, and some may have nurse practitioners who are prepared, and now the preparation is adult and geriatric nurse practitioner. So it could be that seeing a nurse practitioner through primary care can satisfy someone who knows maybe a little bit more about dementia, since most of it is going to be non-drug related. It's going to be teaching kind of strategies, and that's more up kind of the discipline of nursing often than medicine. Dr. Perrin is an exception to that rule, but that might be another consideration as you look for a practice. Is there a nurse practitioner with expertise in geriatrics, because they might be a bit more familiar as well. So that way you're getting the best of what you need through both practices. But it is a challenge, and unfortunately our academic centers have not seen great value in the field of geriatrics, and we've shuttered many of these programs that people like Dr. Perrin and I came from. But we're going to move on now, and Debbie has a question asking about head injuries, and can a head injury be the cause or the start of dementia? Certainly we're hearing a lot about, especially with our athletes.
Good question, Debbie. Again, thank you. I think the short answer is yes. The long answer is it really depends on what you mean by causing or starting dementia. So the short answer is yes. I think, like Jan referenced, we're seeing dementia-like syndromes and dementia-like pathology in athletes that suffer a lot of head injuries and other degenerative brain conditions like Parkinson's. I think Muhammad Ali is our classic example of that. And then there are more subtle head injuries, including, you know, one fall years ago versus multiple falls that resulted in head injury versus athletic injuries. So, and then there's the one, what about when you fell once and it had some bleeding in the brain and required evacuation of that blood from the skull? What does that mean about future cognitive concerns? I think the way to think about it is the brain is an organ like any other organ. Your kidneys, your liver, your lungs, your heart. And anytime that organ is damaged, think about kidney damage. Maybe you got dehydrated and your kidneys suffered. Maybe you took some medicine that damaged your kidneys. Maybe you had a heart attack and damaged your heart. Anytime that organ is damaged, injured, whether it recovers or not, there's been that injury, and the organ is never going to really truly be at 100%. Now, there are going to be some exceptions, obviously, but I think that injury and the healing of that injury may, like you're saying, Debbie, initiate the cascade that ultimately becomes a dementing disease down the line. Again, we don't quite understand what causes dementia. We don't know that. We know things that put you at risk of developing dementia. I mentioned hearing loss in midlife. Jan mentioned age, the #1 risk factor for developing dementia. There are other genetic things. There are other metabolic conditions. So it's all unfortunately a great big gambling game that we call life. And depends on what cards you're given or how the dice are rolled, depends on sort of what happens down the line, because it's all a bunch of probabilities, and then you either win or you lose, and it doesn't really matter what the probabilities were. You have the outcome that ultimately happened. I think that's kind of a weak comparison or a weak analogy, but if you're a gambling person, maybe you get it.
This
So,
is 515 again. I have
yes,
one more question. Can I throw
please.
that in?
Yes, please
Okay,
do.
so I'm always trying to figure out like what stage my mom is at, and you were talking about her sleeping more frequently. Well, she comes home now from her adult daycare, and she's just not really kind of there. She stares at the TV, but I don't think she's really watching it. And she will just kind of go into her own head with her eyes closed. And it looks like she's sleeping, but I can ask her a question and she'll answer me. So I didn't know if that was considered sleeping more, if that's something different. And she's also she's just grinding her teeth all the time. And I just don't know of a way other than giving her gum to stop that. Is that a common occurrence? And are any ideas on that?
Two good questions, thanks. The first is, it sounds like she's just tired. She's had a long day. She's coming home. She's resting her eyes, and she responds to you when you tap her on the shoulder or ask her a question. It sounds like any of us come home from work and we just want to lie down on the couch and zone out a little bit. So I wouldn't put too much worth into that. And I think it's great that she's at adult daycare at the center there, so that she can get the stimulation during the day and rest. Otherwise,
Yeah.
let it disturb the nighttime that you're having there. The chewing of the teeth could be lots of things, including I don't know if she has dentures or her natural teeth. It may be a natural teeth. Okay, it may be a dental issue. It may be discomfort. It may mean she's cleaning. It may need she needs to brush. It may needs to chew gum. Is certainly fine and safe if you want to give her gum to chew. It may be something else related to the brain, that she's sort of stressed out, so we don't know what that really represents, and I would start with a dentist, really, and get it safe. Yeah, and gum is certainly a fine thing. It helps clean the teeth. It keeps the mouth salivated and moist, and gives her something to do. And yeah, so gum is a great solution.
Thank you.
Allie Burke, I'm going to ask, you've got your hand raised, if you would like to ask a question, please.
I do. I just kind of going along with the discussion on concussions. I'm curious in terms of thinking in a preventative way. If people experience multiple concussions, whether it's due to athletics or just living, is there anything or conversation that could happen earlier in the way of being proactive and preventative for suffering from memory loss in the future?
Allie, I don't think so. I think we're looking at this, as early as childhood with sports injuries. Later in life, if you do have a head injury, I think one of the things would be to, really try to figure out, have they really recovered? How long did it take to fully recover? And if it seems like it's longer than it should, maybe an evaluation with a speech and language pathologist, a therapist, literally for the brain, may be valuable, or even a neuropsychologist, to really try to tease out. I don't think that we know what sort of post-concussive preventive treatments are available yet, whether that be exercises, and certainly not medications. We don't know.
Yeah, I guess just kind of thinking along the lines of the fact that in the example of sports, a lot of programs, even as early as youth football, are doing concussion testing as a mandatory part of participation. So in that way, are pediatricians then are we talking along the line in terms of that research to talk about what these things might mean? I know there's a lot of people that are, shying away from contact sports for that. But the flip of it is, what are we learning from that, and how concerned should people be and be proactive at a younger age instead of just dealing with what happens, once you already have symptoms, right?
Right. I think the most answers, many of the answers are going to come out of the pro football studies that are happening. That's probably where we're going to see some. I don't know. I think this is such a new field, and there's so many ways to tackle it. I'm imagining there's research going on right now, but we certainly don't have any answers currently.
Yeah, and actually the NFL is partnered with Banner Alzheimer's Institute and the Mayo Clinic. They're doing the neuropsychological testing of a lot of these pro athletes who have had multiple concussions, and Banner is doing the neuroimaging, but it's very early in the field, and I think there's a lot to learn to say, why do some people go on and develop dementias and others don't? So, the brain is just a very complex thing, but stay tuned. And I guess good news that a lot of this exciting research is taking place right here in Arizona. So, I mean, really, we're on the forefront of a lot of things that are to come, and hopefully our children will fare better in the future because of the knowledge we're gaining now, even as a new drug tanks, again, lessons are learned and scientists kind of repivot and, move other theories forward. Debbie, I see you have your hand up with a question. Go ahead.
Sorry, one more time. Is any of this hereditary, like Alzheimer's and that? I thought I'd heard that years and years ago. That's it.
That's a great question. And luckily, this is one that I have a little bit more of a concrete answer for. So thank you for the lob here. Most dementias are not hereditary. So I think if one of your parents has Alzheimer's, the chance that you have Alzheimer's is not much more than your neighbor whose parents don't have Alzheimer's. There are some factors that are hereditary, and those can be both at the metabolic and at the pure dementia level. And there are some dementia syndromes that are a little bit more hereditary than others. So remember, dementia is kind of an umbrella term, and there's lots of different dementias. Alzheimer's is just the most common kind of dementia. And Alzheimer's, especially late onset Alzheimer's, so Alzheimer's diagnosed in the quote geriatric population in the 60s or older, is really probably not hereditary. If you do develop Alzheimer's in your 30s or 40s, very good chance that it's hereditary. And even in your 50s or early 60s, there may be a better chance that there's a hereditary component to it. The second most common dementia is probably dementia with Lewy bodies, and that's more akin to a Parkinson's spectrum of disease, and there may be a slightly more genetic component to that. And maybe the next most common dementia, which is there's several subtypes, are the frontotemporal dementias, and those probably have a little bit even more stronger of a genetic component to them in terms of heritability. So Debbie, I think the short answer is garden variety Alzheimer's, not really hereditary. Some of the other less common dementias may be a little more hereditary, and certainly early onset, young age Alzheimer's is very much more hereditary.
So let me follow up with another question. So E typed in that her husband's dad, sister, and twin all had dementia. So what do you say to people about the need for genetic testing when there is a strong family history? How do you advise for or against or counsel patients to think about when it may or may not be helpful?
It's a pretty easy question, Jan, thanks. There's not really good genetic testing for any of the dementia syndromes outside of very early onset Alzheimer's. So again, those that are in their 30s or 40s or maybe 50s that have pretty clear-cut Alzheimer's disease, then we can talk about genetic testing of relatives of that person with early onset dementia. The frontotemporal dementias are so diverse still, and the genetics are pretty are not as clear, and they're still being investigated. So again, I would not recommend any genetic testing because we're not sure what to yet test for specifically. There may be some specific cases in the frontotemporals, And again, your dementia specialist, when you're coming to those sorts of questions, may have a better answer than I do. But I really I'm not going to say never, but very, very rarely recommend genetic testing for anybody, any relatives with dementia, for any of my patients with dementia.
So then kind of what are your thoughts relative to this new blood test that will soon be approved for testing, or tell us maybe in the context of why doctors, especially dementia specialists, might choose to use a blood test to confirm Alzheimer's disease?
So the new blood test is, I'm not sure it's ready for prime time. I certainly haven't used it. And the blood test is not a genetic test. So I think that's important. So it's not to tell you what your chance of having dementia is because someone in your family has dementia. The blood test is for me as your doctor to say, I'm wondering if what you have right now, your signs and symptoms, if what you have is Alzheimer's, and if I think it is Alzheimer's, there may be a blood test that will help make that diagnosis more certain. Just like when we talk about getting an MRI or a CAT scan of your brain, it helps decide if this is, it moves the needle closer or further away from a more definitive diagnosis of a dementia, which is not a genetic test. So I think doctors are desperate, especially those in my field of primary care, who don't have time to really dive in like the specialists do and would like to have a much simpler way to say, yes, much more likely to have dementia, or no, much less likely to have dementia with the same symptoms of someone coming in. I can't remember things. I'm getting lost. Well, let me do some blood work. If the blood work all comes back positive, then it's much more likely you have Alzheimer's, and we got a plan for that, versus the blood work all comes back negative. There's something else causing these symptoms, and so we don't have to worry quite as much. Now, again, no test is 100%. We used to say that the only way to diagnose Alzheimer's is at autopsy, and in many ways that's true. I would say there are research centers that one out of, I don't know, Jan would say 1 out of 10,000 cases would do a brain biopsy. And even that's not going to be definitive, because what if you don't get the right part of the brain that we think would be affected? And maybe we find something that shows it's not Alzheimer's because we just didn't get the right sample of brain tissue. So again, this is a brain disease, and the problem is microscopic, and we can't really see it on scans or tests or blood tests yet, although that may be changing, or on spinal tap tests. Those are things that we can hint one way or the other, but no test is definitive really until autopsy.
So I'm going to change the conversation just a bit. I recently had a conversation.
Jan, we do have one question along these lines.
So about spinal tap. So I see that he took it and was told that for sure there was Alzheimer's. So I'm assuming there was amyloid in the spinal fluid. Maybe you could speak to that.
Yeah, the spinal tap for Alzheimer's, again, is not 100% definitive. There is no test that's 100% diagnostic. But if it comes back suggestive or very suggestive of Alzheimer's, then you don't really have to think about other causes for the symptoms and brain disease problems that you're witnessing. I think a lot of patients want to know yes or no, and in my line of work, it's very rarely black or white. It's very rarely yes or no, true or false. It's kind of that gray zone, probably or very probably or likely. And so I think a lot of doctors just take that gray stuff and push it all to one side or the other. And I'm just here to say it's not as definitive. It's not a perfect scientific study. It's not a perfect science. It's really an art. And that's where we're going to come in and say, the spinal tap fluid really looks like Alzheimer's. Nothing's 100%, but it really looks like it. And we don't have to look for any other causes. And that's probably what you've experienced.
Okay, so let's talk about right now, this odd period of time we're in with COVID. And I just had a colleague of mine voice concerns that some of the patients she's now seeing have been really putting off medical care, right? Much to their detriment, whether it be the person with dementia or the caregiver not really following up. So what advice would you give to our listeners today about when they should see a physician medical provider in person or look for a virtual sort of opportunity. What are your thoughts on that?
Well, I often say stay away from doctors, so that's going to be a little bit of my bias. But when you have chronic conditions, you really shouldn't avoid seeing your providers, whether they be nurse practitioners, nurses, social workers, doctors, PAs, whatever it is. So I think it is not time to postpone regular visits. And it is probably important, if you can't come in person because of safety concerns with COVID, try to do a virtual visit by video or even phone with your provider. I think postponement of needed care, just routine checkups, and maybe they don't have to be quite as frequently as you were told in the past. Maybe you don't need to come in every 3 months. Maybe it's okay to go every 4 months or every 6 months, but think about it like you do with your dentist, right? You really do need to check in a couple times a year with your dentist just to make sure things, with or without dental disease, without a condition the dentist is treating, just to make sure that you're doing okay and get that cleaning and that checkup. And we doctors and other providers in the medical field sort of know what to look for. You look fine today, you look just as good as you did 6 months ago. Let's put it off for another 6 months, or wow, something's different. And it really does help us to see, certainly in person, but even on video, how do you just look and sound and feel, and let's elicit how things are going. And I do think it's important to maintain routine care at whatever frequency you've been told. And again, qualify that with maybe you can push it out a little bit, but don't avoid it altogether.
So another issue that often I hear from families is that, they're going with their loved one to see the doctor, and the doctor isn't really getting the clear picture of what's going on because they're talking to the person, right? And especially, this is where I think about maybe primary care specialists who aren't as familiar with the diagnosis, and they really, right, the person's giving rote answers. What should a caregiver do to be able to inform the physician or the nurse practitioner, whoever it might be, the medical provider, about the real true story without the person maybe losing face or getting them upset? Any thoughts you might have on that?
Well, it's a conversation like anything else. If you go to the supermarket and you're having a conversation with a checkout person, you got to sort of set it up correctly. It's got to be the right time and place. And sometimes, believe it or not, just writing it down and saying, here's a piece of paper, doc. Will you look at it and spend a couple minutes and tell me what you think? And those couple minutes sometimes buy you a lot of extra time and latitude with that provider. So I think writing things down and maybe even prioritizing them for the doc. Here are my top 2. Here are my next 2, and here are my last 8 that I would like to cover. And some docs will be able to do them all. Some docs may say, why don't you come back in a week, or let's touch base by email or phone. I mean, there's lots of different ways we're doing it, and the way that the medical care structure is being reorganized with COVID is giving all of us a little bit more flexibility around that. And then sometimes it's an interruption. So sometimes you have to step on your deference a little bit and say, hold on, I didn't quite get that, or hold on, you didn't quite hear what I'm saying. And sometimes an interruption, again, it's a conversation, it's a dialogue, and you need to feel comfortable bringing these concerns to that provider, and making sure that he or she feels comfortable with you and replying appropriately. So it's an art, it's a dance, it's a challenge. I think we've all had experiences as patients or as caregivers of patients trying to navigate this with the various providers. And sometimes it's calling the day ahead and letting the assistant or the scheduler know, by the way, my mom gets really upset. Can you make sure that, the bathroom is empty? Can you make sure that you have some sweets or treats available? Is it okay that I bring, her support animal? Sort of preparing them as best as you can to make that visit be as effective and efficient as possible, because we're all dealing with it. It's difficult, it's challenging, it's hard.
Yeah, indeed, it can be very challenging. So if knowing that kind of on average, most patients will get about 7 minutes, I think is what I've read with their medical provider. How, if I needed longer than that, because there are a number of things to take care of, how would I call and notify because it's the scheduler or whoever's answering the phone, how do I let them know that I need Dr. Perrin for more than 7 minutes? Can you speak to the visit lengths that are there? Because I think sometimes families don't know they could potentially get a longer visit.
I think it's just a query. And sometimes it's a query at the end of your visit. Say, next time, would it be possible to spend some more time? And sometimes the doc will say, it's out of my control. I work for Banner or Honor Health or some big system or my employer, and they don't let me get any flexibility. Sometimes they'll say, I have no flexibility, but I'll make some more time for you. Or I have no flexibility, but let's touch base by phone or email. Or I do have some flexibility, but it won't be till next month. So it's really hard, Jan, and I don't have a good answer. This is a terrible system we're in, and doctors are not being paid for their time. They're being paid for, getting them in and out, and that's unfortunate. And sometimes you can find a provider in a different type of setting. The last setting I was in that I just left just a few months ago did permit me to have more time with my patients. The setting I'm in now permits me to have less time, but there is some flexibility. So when I do need more time for my patients, I am allowed to schedule more time. And that's really a conversation you have to have with your provider.
So again, that communication is so important, and just letting caregivers know it never hurts to ask and to figure out how can I best communicate, because I do think at the end of the day, the bulk of people want to do the right thing, or perhaps same thing that we're asking physicians to answer questions that they're not expert at. So how do we use, again, other, social workers, nurses, the Alzheimer's Association, right, our support groups who have expertise in those areas. So we have just about 10 minutes left. So are there any questions still forthcoming from the audience? Because otherwise I'll ask Dr. Perrin maybe another one that often pops up. And that is, I often hear from families, and this kind of goes back to the medications. I don't think these medications are working. How do I know that I should just stop them?
Huh. Oh, yeah, I'm assuming you're meaning the dementia.
The dementia drugs, yeah, the Aricept.
Medications. So medications like Aricept or Exelon or Remanil, Razodine, I think it's been renamed. Donepezil, galantamine, rivastigmine, Namenda, memantine, Namzaric, which is memantine plus donepezil. Those are the only meds we have. And so the question, Jan, that I hear all the time, I hear from my colleagues that come to me, the other family docs in the practice who have less experience or comfort with dementia come to me and ask exactly that question. And this is the art of medicine, right? So is it causing a problem, right? So is there a side effect that is troubling and we really want to reduce the dose or eliminate that drug so the side effect is not present any further? So that's one question. Second question is it working? And that's a much harder question to answer because we know that these drugs are not very effective. They don't restore brain cells. They don't really restore much of brain function, although sometimes they do. So one of the questions is, did it ever work? So if it ever worked, the chance that it's still doing something is there. So maybe I'd be a little more reluctant to stop it if it worked, 5 years ago. But now we're not seeing much. The disease continues to progress. I'd be a little more reluctant to stop it. However, we also know that they sometimes stop working as disease progresses. So I think anybody should be encouraged and supported in a drug holiday and say, let's stop it for 2 weeks, never more really than 2 weeks. Because if you start to see that the patient is worse after stopping it, and you wait too long to restart it, you may not be able to make up the lost time from the loss from stopping that medicine. So I think it's valuable to do a drug holiday. And when you do a drug holiday, it's really only changing one thing. Don't stop both drugs, only stop one, and really focus on what are you hoping to see by stopping it. Are they more alert, less alert, more confused, less confused, more focused, less focused, more irritable, less irritable, more able to get dressed and go to the bathroom, less able to get dressed and go to the bathroom. And you can do it on a number scale. They're here right now. +1, 2, or 3 means they're better at whatever you're looking at. -1, 2, and 3 means they're less good at doing whatever you're trying to do. Are they more nauseated, less nauseated, more of an appetite, less of an appetite, more headache, less headache, sort of looking at the side effects. And if there's no difference off the medicine, then you've sort of done the experiment that it probably has lost its effect and the disease has progressed far enough that it wasn't having much of an effect or an impact. Does that answer it?
Yes, it does. I'm sorry. And I started to read a comment, I guess, from E. When my husband was diagnosed, we were told that it was a bit weird because he seems to learn things. He learns some things really well. We were told that people with Alzheimer's don't learn much. Then a psychologist said that there's some vascular, and the neurologist the next day said there was probably no vascular. The question is about learning new or relearning things with Alzheimer's. What are your thoughts about that?
That's a great comment, great commentary. Just because you have a bad brain doesn't mean it's going to stop working. So I think it will be harder to learn things with any type of dementia, but not impossible. And I think someone with dementia, especially on, should be encouraged to try new things and keep that organ as stimulated and active as possible to prevent ongoing damage to that brain. So I applaud you for getting him to do new things. I think that's really valuable and may stave off a more rapid progression of the dementia. So I don't think it's unheard of. And the question of vascular versus non-vascular, again, without a biopsy, an MRI is only so good. So take it for what it's worth. If there's some clear vascular damage and you treat the vascular part of that disease, then slowing the progression is much more plausible, and ability to learn things may also be plausible as you reduce the vascular risk factors or treat those vascular risk factors. So I think it's a great little sort of snapshot of what can happen, and I don't think it's unusual. I think it's great that you witnessed that and were able to do that. And I would encourage anybody with certainly early dementias to try to learn new things, and it may be a way to prevent any sort of dementia. If you're at high risk, try to keep that brain active and activated.
Yeah, and he just said thanks much. He wants to learn new things. And I have some colleagues who are really in the creative space who really believe that the capacity to learn and stay engaged in life is there very far into the illness. And, in many ways, we've infantilized this disease to think that people are solely incapable. So I think, these are new discoveries as we think about dementia in a different way. So I think, Dr. Perrin, as we end, I'm gonna have you reflect, I guess, a little more philosophically, if you will. So as a physician, how do you give hope to a person who is living with dementia? And then same thing, how do you restore or encourage caregivers in a disease that we do know is progressive? So first, maybe talk about how do we encourage, support the person living with the illness, and then how do you as a physician support the family?
Ooh, that's a really philosophical question, Jan. Well, I think this is sort of one of my motivating tenets, which is, first of all, we're taking care of people. We're not taking care of patients. We're certainly not taking care of demented people. We're not taking care of diabetics or hypertensives. We're taking care of people. And so I think it's really trying to recognize that at every stage of dementia, there's still a person behind that. And to find that person, celebrate that person, and interact and connect with that person, whether it be through touch, sight, sound, smell, taste, whatever it is. These are human senses. The spiritual piece is huge. So sometimes, you know, finding some sort of religious or spiritual practice can be really beneficial for everybody involved in this. You know, I often get the question, why, doctor, why does my loved one have this particular condition? And I always jokingly say, that's not a question for me, that's a question for your clergy, because the questions of why are really around spiritual and not physical ailments. And so I think there's a component to that. And then celebrating, like we all should do, like some of the Eastern masters teach us, you know, gratitude on a daily basis is really valuable. And so find something that you can be grateful for, thankful for, or appreciative of. And maybe it's that somebody smiled at you, someone let you in when you were merging, that there was an outcome in a sports match or an election that you can point to, or that there was a beautiful flower, or the person you're caring for, you know, gave you a hug or a smile or a kiss, or you give them a hug or a smile or a kiss. So it's the little things, right? Those stupid little platitudes around, it's not how many breaths you take in a lifetime, it's how many times your breath is taken away. I mean, those are really trite and yet so true, that you're with this person, you the patient or you the caregiver, with this person with a disease, and it's a terrible disease, and it probably is a terminal disease, and yet you're going to live your life every day, right? It's not what you do, it's how you are. We're human beings, we're not human doings. And so be present, be loving, be appreciative, find, recalibrate your hopes. You're not going to live forever, nobody does. So as long as you're living, how do you want to live? Do you want to be able to travel? Do you want to be able to watch TV? Do you want to be able to eat a good meal? Do you want to be able to cook a good meal? So finding the daily successes and the daily joys is really, I mean, I feel like I'm a clergyman saying this, but this is going to be more important than the cure or the, you know, the next X-ray or the next test. That's, whether it be good, bad, or otherwise, those are just tests. They're not good or bad. You, the person, are good or bad. Those are just data, and data don't have value. They just point in one direction or another. So, you know, I hope I'm not sounding too Pollyannish or too unrealistic, but I think it is possible to find hope and joy on a daily basis, despite the enormous challenges of living with conditions like dementia. I hope that helps.
That was very well said to, I think, conclude just an amazing question and answer session with our group today. And we're grateful that you would take time from your practice to share your wisdom in the field and perspectives and provide a sense of hope, I think, to all of us as people living with dementia, care partners, those professionals in the field. So with that, I guess, Candace, any final announcements that you'd like to make for the group?
Just that we provided our website at the beginning if they would like to know about future Dementia Friendly Tempe Presents, and we'll have one next month. So you can find more information at www.tempe.gov/DFT. Also information on our Memory Cafe support group and other programs that we've got going for Dementia Friendly Tempe.
Thank you. Yeah, go ahead, Dr. Perrin.
I would say to all those participants, please avail yourselves of these resources out in the community. And Candace, thank you and your team for making these available to everybody in the Valley, certainly Tempe residents. And it's a great resource. And I thank you all for your attention and your questions, very thoughtful, and good luck to everybody.
Thanks all.
Goodbye, everyone. Thank you.